Good morning, Dr. Garner. Good morning, everyone. May I introduce myself? I am Associate Professor Hui, Chair of the Association of Endocrinology and Diabetes, Ho Chi Minh City. It's my honor to be with you today to talk about insulin injection technique, at least. First of all, I would like to thank Dr. Garner. You have saved time to be here with us, and thanks to BD company to organize this meeting. And now, first of all, I would like to introduce all the participants here in Ho Chi Minh City, and I will introduce by round. And first is Dr. Trần Viết Thắng. Thắng, say hello.
Hello.
Yeah.
Hi.
He is in the Department of Endocrinology, Ho Chi Minh City, University of Medicine and Pharmacy. And the second one is Dr. Kim Oanh.
Hello.
She is
Morning.
from the hospital, Saigon Hospital in Ho Chi Minh, Saigon General Hospital in Ho Chi Minh City. And the third one is Associate Professor Big Dow.
Hello.
She is in charge of the metabolism department in Tâm Đức Hospital, and at the same time, vice chair of the hospital. And on my right is Dr. Trần Quang Nam. He is chair of the Department of Endocrinology at the hospital, University Hospital, Ho Chi Minh City. And the Dr. Chung, he is in the Department of Endocrinology, Ho Chi Minh City, University of Medicine and Pharmacy. And the last one is Dr. Khoa. He is chair of the Department of Endocrinology, Hospital 115 in Ho Chi Minh City.
Hi.
And so we meet today together to talk about insulin injection technique. And because we have in short of time, so I would like to introduce to all of you Dr. Daphne Garner from Singapore, I think. Yeah, you.
Yes.
Which hospital, doctor?
I'm at Singapore General Hospital.
Singapore General Hospital. Yes, thank you. And you will talk about RINI study.
Yes.
RINI study, and you share your expertise with us about the use of a short needle.
Yes.
Yeah, in insulin, and some improvement in the injection technique. Yes. So now I would like to invite you to proceed to your presentation, please.
Thank you very much, Professor Quay, and thank you once again to BD and to all of you for this invitation to be with you today. It is a real pleasure. I last went to Vietnam many years ago. I've been to Ho Chi Minh City as well as to Hanoi, and always very fond memories. And today our topic at hand is looking at the best practice in insulin injections. And you know, quite often it's simple to think about insulin just like another medication, but in reality there's a lot more to it than that. Trying to get insulin in consistently and to the right place is actually trickier and more challenging than one might perceive. I have a practice of young adults with diabetes clinic that was initially set up to transition children from the pediatric sector to the adult sector. And so about 2/3 of the people with diabetes I see have type 1 diabetes, and typically they'll be on 4 to 5 injections a day. So I do see quite a lot of people with problems with insulin injections, and I hope to share some of that experience with you today. So these are my disclosures. And the outline of today's session is looking at why insulin injections matter in terms of the technique and how it's done. And within that, what actually matters? And then knowing what matters, then what we're going to do about it. I think many of us are very familiar with HbA1c as an outcome measure, such that the higher the HbA1c, the higher the risk of diabetes-related complications. And so we've always had this behind our minds that we want to try and aim for a lower A1c in our patients, and most guidelines would agree that a HbA1c of less than 7% is the target to aim for in most people with diabetes. But that is really based on the assumption that if you get a person's A1C less than 7%, that it's going to look something like this. But in reality, I would say 95% of the time, the CGM tracings that I see looks more like this, with wide variations in the glucose levels and prolonged hypoglycemia and frequent hypoglycemia. In actual fact, HbA1c doesn't tell you about the incidence, the frequency, and duration of hypoglycemia. It doesn't tell you anything about how much the glucose is fluctuating. And more importantly, for the end user, it really does not inform them how they're going to make changes in order to better their glycemic outcome. So I show you here two individuals, one with an A1C of 6.2% and another with a HbA1c of 10.1% at the point of time of doing their respective CGMs. And you can see that in both panels, really it's very hard to tell them apart in terms of there's no pattern to their glucose levels. There's nothing that you can really identify in order to try and effect any changes in their therapy. The other thing that you would note as well is that if you follow this person with an A1C of 10.1%, we used to say, if you want someone to be protected from hypoglycemia, we should increase their HbA1c. But if you see here, having a HbA1c that's high at 10.1% doesn't exclude this individual from having hypoglycemia. In fact, on the purple day, he's spending a sum total of more than 2 hours in the hypoglycemic range. So what then does predict hypoglycemia? Again, two other individuals. The person on the top panel has a higher A1C, but higher glucose variability as shown by the darker blue bands here. And the person on the bottom panel has lower A1C, but lower glycemic variability. And if you then try to see which one has more hypoglycemia, you will notice it's the person not with the lower A1C, but instead the one with the higher A1C and yet higher glucose variability. If you try to key the three parameters together, glycemic variability on the y-axis, HbA1c on the x-axis, hypoglycemia coded by red or 1 and 2, and those without hypoglycemia coded in green or 0, you will see that for the same tier of HbA1c of about 7%, that the people who do have hypoglycemia are marked by higher glycemic variability than by a difference in an A1C level. Therefore, when we're talking about glycemia these days, it's often more meaningful to talk about it in terms of time and ranges. And this is the summary figure from an international consensus guidelines that was published last year in 2019 that tried to make sense and standardize CGM metrics towards something that was more meaningful for us to target in terms of outcome. And the guidance from that paper was that we should try to aim for a glucose level of between 3.9 to 10 millimoles per liter in most people at least 70% of the time. Notice the range is not normal glycemia, which is 3.9 to about 7.8, but really 3.9 to 10 millimoles per liter. And more than 70% in a day would be equivalent to about 16 and a half hours in a day. And we should try to do that by minimizing the time spent above 10 millimoles per liter to less than 6 hours in a day. And not forgetting a very important parameter of trying to minimize hypoglycemia in all of this to less than 1 hour spent less than 3.9 millimoles per liter, or less than 15 minutes spent under 3 millimoles per liter. What does this translate to the all familiar HbA1c that we know? And studies have looked at this in populations of type 1 and type 2 diabetes. And essentially, if you can get your patient to achieve between more than 70% of the time, between 3.9 to 10 millimoles per liter, you're going to be able to see a laboratory HbA1c of 7%. Remember that there is a range around that HbA1c that you see. But probably what's more important is that, every little bit helps. So for every 10% increase in the time in range, you're going to be able to achieve a HbA1c lowering of 0.5 to 0.8%. So rather than getting a patient to say, oh, you need to achieve 70% or more, every little bit helps. Is there anything else that influences this ability to achieve time in range? And this study looked at different quartiles of glycemic variability here, and this is a measure known as coefficient of variation of glucose, which is the standard deviation of glucose over mean glucose. And as the quartiles go from 1 to 4, so does the glycemic variability increase. And I'll just point out here, for a mean sensitive glucose of 8, that correlates with the estimated HbA1c of 6.8%, you can see that the time in range decreases the more your glycemic variability is. And in other words, that the higher your glycemic variability, the less you're able to achieve time in range for a given average glucose level. So I put to you that why it matters is because HbA1c is not the only important glycemic outcome measure, and that time in range takes into account the time spent above range and the time spent below range, and therefore, these markers of time in range and trying to reduce glycemic variability are practical goals that we can try and help our patients achieve in their diabetes self-management. So now we know that why it matters, that A1C is not the only outcome. We don't look at, what does matter. And for this, I'll be taking some data from an RCT that was held over 6 months. And essentially, they wanted to see whether, if they were to just provide education and proper insulin injection techniques, whether it make a difference to glycemic outcome. Groups 1 and 2 received education. Group 1 had the additional benefit of being supplied with the short needles, and Group 3 did not receive anything at all. A reminder of what participants had to be reminded of, which is how to choosing the injection site, the depth and angle of insertion, looking at the needle length we use, looking at skin fold information, needle retention time in the skin, injection site rotation, and avoiding needle reuse. So here they are at baseline on the left panel, and at least 75% or more within each group were on the long needles, 8 millimeters or more. And in terms of needle reuse, a significant number were reusing the needles. Following education, groups 1 and 2 were using the shorter needles, and there was minimal needle reuse. Importantly, didn't make a difference to their glycemic control. And at the end of the 6 months, you will see that groups 1 and 2 achieve a HbA1c lowering of 1% compared to minus 0.2% in group 3. And this produces a between group difference of 0.8 percentage point. So I'll put to you that education and insulin injection techniques, it does work. And it's important. And remind your patients about using shorter needles, depth angle of injection, no needle reuse, rotation of sites. And a reminder here about the insulin syringe as well as the insulin pen. With the insulin syringe, the shortest needle you can go to is 6 millimeters, which is still too long. And can you imagine, as a patient with diabetes who needs to head out for a meal, how many of our patients do you see will be remembering to take the insulin syringe out with them and injecting it in front of others before a meal? Whereas if you open up an insulin pen device and you're allowed to leave it out of the fridge for up to a month, and so when you want to head out for dinner, you just bring along a needle and then you just cap it on, and then off you go and you can administer your injection before having your meal. So we know that education matters, and then we look at, okay, how are we going to help our patients understand what they need to do. So getting insulin to the right place can be difficult. What we have to remember is that as people's body habitus is different, so lean individuals will be expected to have less subcutaneous tissue, and as you become overweight to obese, then there will be more subcutaneous tissue. And the average skin thickness, if you remember, is 2 to 2.5 millimeters in most people, be it whether or not you're lean or you're obese. And what we want to try and get the needle to do is to traverse the skin into the subcutaneous tissue and avoiding the muscle layer. So intramuscular injections have been known to be more common with longer needles. So if you're on 6 mm or higher, there's a 5% chance of injecting into the muscle layer. However, we also know that your body habitus matters. So if you have a slim, young person in front of you, and typically if they're male, typically if they're injecting into the thighs instead of the abdomen, then you're more likely to hit muscle than you are subcutaneous tissue. Why does this matter? IM injections can increase the rate of absorption of insulin, and as a result, increase the risk of hypoglycemia and increases your glycemic variability. And if you can imagine, if sometimes you're doing subcutaneous and sometimes you're doing intramuscular, that then becomes tricky because sometimes it's absorbed quicker, sometimes it's absorbed less quick, and so the bioavailability and the glycemic variability increases even more. So in most cases, remembering that the skin thickness is only 2 to 2.5 millimeters, 4 mm needles would be considered to be suitable in all cases because that's enough to get into your subcutaneous tissue and we're not approaching muscle. And that is consistent across all ethnicities and BMI, be it whether you're adult or your child. In terms of the best practice, remember that 4 mm needles may be administered 90 degrees to the skin, not an angle insertion. And then if you have very young children or very thin adults, you should just lift the skin fold very, very gently and use a 4 mm needle. Remember not to fold the skin too tightly because otherwise you might be drawing muscle in under that fold as well. And children using pen needles at 5 mm or longer should be encouraged to switch to 4 mm if possible. So the optimal sequence, as a reminder, should be gently lift the skin fold, inject insulin slowly at 90 degrees angles to the surface of skin. Angle it was inserted, and then release the skin fold and dispose of the used pen needles safely. The sites that have been used include 1 centimeter away from the ribs, from the umbilicus and symphysis pubis within the abdomen, on the outer lateral aspects of the thigh, upper outer quadrant of the buttocks, or the posterior portion of your upper arm. And if you really think about the force that's needed for each insulin injection, it's really at 2 surfaces. And one is at the thumb plunger surface, and the other is when the pen needle device approaches the skin. And the force applied can be variable depending on the site of injection and the volume that you inject. So the BD scientists have developed a method of using a pen device that's connected up to a sensor with the data from the force of the application being fed through to a computer device in order to see, when according to the site, according to the volume, according to the individual, what application force is being applied. And what you will note here is that in general, thigh injections, as shown here in blue, appear to have greater force being applied than injections into the abdomen. The other thing to note is that different doses will also affect the amount of force that needs to be applied. So I have here in red someone on 5 units, another group on 25 units shown in blue, and another group on 45 units shown in green here. And essentially, what this chart shows is that the higher the volume of insulin that you need to inject, the more injection force you need to apply. So both site of injection, volume of insulin influences your injection force. A group of nurses in Singapore tried this out, and you can see with each colored line representing a different person, you can see that the injection force for the same volume of liquid can be very different from one person to the other. And in general, the greater force seems to be needed to be applied for the thigh region than for the abdominal region. And even if you have the same person applying the injection, the same volume of fluid into different sites, the amount of force that's applied can be very different as well. For example, participant 6 uses more force when injecting into the abdomen than injecting into the thigh. Is there any way where we could decrease this variability in injection force? So the new BD Ultrafine Pro 4mm needles is different from the previous generations in that it has this wider contoured hub. And so just a picture to show how it compares to the previous hub. You notice the previous hub has a very sort of a narrow surface area that contacts the skin compared to this wider hub to enable it to spread the force across the surface of the skin. And so trials have been, this has been studied in terms of whether or not this contoured hub makes a difference in terms of the consistency and the depth of penetration of the needle. And this BD Nano second generation needle was compared to commercially available 4mm needles, labeled here as A, B, and C. And what they did was to try and apply the needle injections under different increasing forces and pressure into swine skin. And what you see here, BD Nano second generation shown in pink here compared to the other commercial devices across a range of forces here, what you can see that there seems to be consistency in the depth achieved despite different forces being applied, whereas with pen needles A, B, and C, that the higher the force you apply, the greater the needle penetration depth. And so you can imagine what's happening here, and these are images taken on fluoroscopy with radio-opaque fluid being injected. And what you can see that is that with the contoured hub, it pretty much prevents you from being able to go deeper, even if you try to, compared to the standard hub here. And so quantitatively, the BD Ultrafine Pro needle compared to A, B, and C here, what you will see is that the mean depth achieved was about 4 to 4.5 millimeters. The other thing to note is that the standard deviation of this depth is very narrow, which means that the consistency of delivering that same depth is there compared to needles A, B, and C, where sometimes you might go deeper and sometimes less deep. Showing you this data pictorially, and you can see in trying to achieve a depth of 4 to 4.5 millimeters, that the BD Nano second generation needle achieves that most of the time, And the standard deviation, it spans across 3 squares, compared to needles A, B, and C, where that most of the time is approaching more than 4.5 millimeters towards the 5 and potentially 6 millimeters depth, and the standard deviation tends to span across 4 squares. Does this make a difference to how the end user feels? And so this was looked at with patient-reported outcomes in over 200 individuals. And these are individuals who have had either type 2 diabetes or type 1 diabetes. The duration of insulin injection was close to 8 years. And those who had type 2 diabetes had it for quite a while. And so these are experienced injectors. And you will see that in this cohort, about 1 in 5 individuals were on at least 3 or 4 more injections a day. And how do they feel in general? And you can see that there's consistency in terms of preference for the BD Ultrafine Pro needle, and that overall preference is there. The other thing as well is that there's an overall ease of use. And importantly for a lot of patients, it's more comfort in using it. And so, you know, that's going to encourage them to be adherent to their injections, because no one really likes pain if they can avoid it. And also, it was easier to grip and remove the needle. A reminder to you to have your patients check their injection sites and remind them to rotate their sites. So one of the things I always find is that when you ask patients to rotate their sites from the sites of lipo hypertrophy here, you tell them to avoid the sites and move their sites upwards. What they tend to do is they might inject on the right for one injection, mix on the left, and then back to the right, and then back to the left. And so in time to come, what they're going to then do is that move these lumps to the upper part of the abdomen. And instead, I always remind them to inject 1 centimeter apart using just one quadrant, and so space 1 centimeter apart, going like in a snail-like fashion for about 3 days, then moving on to quadrant 2, and so forth to quadrant 3 and 4. And so by the time they get back to the original site, there are many, many injections away. The other thing is about reuse of needles, and this is just an example of a patient of mine who was reusing his needles, and you can see quite bad marks on his abdomen. Try to remind them not to leave their needle onto their pen device, as this encourages air or blood entry into the insulin cartridge, and therefore it can affect the preservatives within the cartridge as well. And also, when the temperature rises, your insulin might expand and leak through the needle. I'm going to end by a case example of a 42-year-old Chinese man who has type 1 diabetes, diagnosed in 2015 at the age of 39 when he presented with DKA. And he was first seen by myself in 2019. And when I looked through his A1Cs, he had been running between 7.5 to 8.2% over the last 1 to 2 years. There was no associated diabetes-related complications, and he was on Levemir 30 units at bedtime and quick-acting insulin 3 to 4 units with breakfast and dinner. And based on his body weight, that would make it out to be about 0.6 something units. That would be about 80% of his total daily dose of insulin. And so when someone is on very high basal levels, you can be quite certain that they would be having hypoglycemia in between their meals. The other thing to note as well is that he often doesn't administer quick-acting insulin for lunch. And when he returns home, his wife then sometimes does this injection for him when she is home. And that again is another variability being introduced, because the wife might apply a different pressure than he would. And so that increases the glycemic variability potentially even more. So here he is, laboratory HbA1c 7.7%. Not too bad, you might say. And the estimated A1C from the ambulatory glucose profile is also consistent with that. But if you look at his ambulatory glucose profile, you will note that he's often going to bed with high glucose readings and dipping down low to the hypoglycemic range first thing in the morning. And then he starts rising at breakfast time. And then by evening time, his glucose levels are high and so on and so forth going on to bedtime. Not only is his 50th centile line high, his glycemic variability, as shown by the darker blue bands, is also high. Here's a weekly summary of what his sugars are like, and you can imagine what he's doing. There's little structure in what he's doing, in that when he scans his glucose, he tends to scan it only when it's high, and then he will then react by bolusing and sending his glucose levels down. Here he is again, high, bolusing down, high, bolusing down. And he does that at bedtime too. High, bolusing down, sometimes bolusing too much and ending up hypoglycemic. So the same pattern that you see time and time again. If you look at the report, you will see that for a given HbA1c of about 7.5% estimated based on his mean glucose level, he's only achieving a time in range of 42% and a lot of time spent below range of 13%. And if you look at the coefficient of variation, target being less than 36%, and in normal glycemic individuals, this should be expected to be about 15 to 17%. You can imagine at 50%, this will be considered very high indeed. So what's going on here, which we need to try and help him address? First of all, when you see high, steep glucose curves like that, he's eating without administering quick-acting insulin. There's little, no concept of carbohydrate counting. When his glucose levels are high, he then reacts by giving a bolus and bolusing it down. With background insulin of 30 units at bedtime and 3 to 4 units only twice a day, this really needs addressing. We need to even up the background insulin and the quick-acting insulin and consider changing him over from Levemir to a longer-acting, flatter profile type of basal insulin. We also need to check his insulin injection sites, and actually he had quite a lot of lipohypertrophy on the lower abdomen. He was also reusing his needles quite a little bit, so I kept seeing a lot of needle marks. And there was very, very little structure in what he was doing. So what did we do? We told him that he was going to continue using the Libre scanner to perform premium scanning only, to then think about his quick-acting insulin dosing, which needs to be administered 15 minutes before he started eating. And the way he decided on that was based on the glucose level during the scanning and the carbohydrate counting. And then encourage him to use shorter pen needles. He was at that time using 6 mm. And then to avoid lumpy sites and rotating the sites. And we did, in order, when we advised him to do that, we also reminded him that if he was then going to use pristine sites, that the insulin would be absorbed better, and so his total daily dose of insulin might need to be decreased. And we also counseled him on no needle reuse and taught him about the structure of pre-meal scanning, pre-meal bolusing 15 minutes before, quick-acting insulin dosing based on his insulin-carb ratio and insulin sensitivity factor. This is him a few months on. You can see from daily curves that there seemed to be a lot more structure with what he was doing. There was less of these high peaks, and this is evident in his ambulatory glucose profile as well. And so I'm pleased to report that with this, his time in range improved to 69%. There's still some work that needs to be done on his time below range, but we've managed to halve it. And satisfyingly and correspondingly, his percentage CV has also fallen from 50% down to 36%. So I put to you that stable glycemia really involves targeting both the TIR between 3.9 to 10 millimoles per liter of more than 70% of the time, and your target HbA1c. Insulin injection techniques do matter. Think about needle length, avoiding reusing your needles, avoiding lipohypertrophy through site rotation, consistency in insulin injections to decrease variability. the timing of your prandial insulin to be at least 15 minutes before eating, and to consider using needles that offer greater consistency in depth penetration. And with that, I thank you very much for all your attention and your time, and I'm happy to take questions. No, thank you.
Thank you, Dr. Daphne Garner, for your very precise and informative talk. I think that now we would like to share the opinion of our participant here in Ho Chi Minh City. And I think that because you have a translator with you, so we'll speak.
Do I have...
You have your translator with you?
No, I don't have a translator, but I think Lynn can help translate.
Yes, hello, Dr. Gardner. I will be your translator.
Okay.
So we will speak in Vietnamese, and very slowly.
Okay, sure.
Yeah, and very slowly, so that the translator can catch up with our opinion.
Sure.
Yeah. Bây giờ chắc là mình nói bằng tiếng Việt nhưng mà nói rất là chậm để cho cái người dịch đó người ta có thể dịch kịp cho bà nghe, tại vì mình thấy như vậy là cái đường truyền nó hơi chậm một chút á. Thành ra là bây giờ thôi mình đây với nhau toàn là những người quen biết, thì mình có cái kinh nghiệm gì hoặc là cái thắc mắc gì đó thì mình cứ trình bày để cho như là mọi chuyện là như là bà cũng nắm được những cái vấn đề ở bên mình đó, hoặc là mình có cái gì thắc mắc thì mình hỏi. Thành ra bây giờ ở đây mình cứ gọi là thoải mái, phải không? Góp ý thôi. Giờ xin mời bác sĩ Thắng trước đi. Tiêm insulin trong thực tế đó thì bác sĩ Thắng có những vấn đề gì không, và có cái câu hỏi gì không? So I would like to ask Dr. Thắng to present his opinion first.
Dạ, kính thưa cô, kính thì trong cái thực tế á, thì cái việc mà dùng cái kim mà tiêm insulin á, thì mình thấy là bây giờ bắt đầu ở bên tụi em thì bắt đầu là dùng kim là không có dùng sử dụng lại rồi, có nghĩa là một cây chỉ tiêm với một lần thôi. Nhưng mà em biết là ở nhiều nơi á thì bệnh nhân vẫn còn cái thói quen là dùng cái kim mà dùng lại nhiều lần á, thì cái đó là cái thứ nhất. Thì cái thực tế của mình thì cái đó phải chịu thôi. Cái thứ hai nữa là cái kim mà theo như cô giới thiệu, cái loại mà bút tiêm thế hệ mới á, có vẻ như là nó sẽ đem lại những cái lợi ích hơn cho bệnh nhân, nhưng mà em vẫn chưa thấy là cái lợi ích đó nó có cái mối liên quan gì đến cái việc mình làm giảm cái dao động đường huyết cho bệnh nhân hay không. Thì chắc để hỏi thêm. Tại vì là có vẻ như là bệnh nhân sẽ bớt đau hơn, giảm đem cái tim nó dễ dàng hơn cho bệnh nhân, cái lực nó tốt hơn, nhưng mà cái gọi là để làm ít cái dao động đường huyết á, nó liên quan như thế nào thì em vẫn chưa có biết được cái chuyện đó. Dạ, trước mắt em xin hai ý kiến thôi.
Như vậy là cái kim mới đó thì cái bề dày tiếp xúc với lại da nó rộng hơn. Thành ra là như vậy khi mình ấn xuống đó thì nó không đi vào sâu và ít cái khả năng nó đi vào cái muscle đó, tức là cơ đó. Thế nhưng mà thật sự ra đó thì cái mức đường huyết đó của bệnh nhân khi mà tiêm insulin là nó tùy thuộc liều insulin và cái lượng carbohydrate bệnh nhân ăn. Thành ra cái trích nó cũng chỉ là một trong rất là nhiều yếu tố mà cô đã trình bày thôi, đúng không? Thành ra cái mà dao động đường huyết đó, tức là cái glycemic excursion đó, hay là variability đó, thì dường như là nó tùy thuộc nhiều yếu tố chứ. Cái mình là cố gắng cải thiện nhiều yếu tố thôi, như là cái ca của cô trình bày đó, thì như vậy là mình có một loạt những cái yếu tố mình cần phải tác động để cho cái đường huyết của bệnh nhân đạt được mục tiêu điều trị. Đó, bên BD có kinh nghiệm gì về cái chuyện mà những cái nước mà đã sử dụng cái kim mới không? Dạ. Nhưng mà cô có nghe được cái gì không?
Dạ em cảm ơn quý thầy cô. Sau đây thì em xin phép dịch cho cô Dr. Gardner. Hello Dr. Gardner. So this is the opinion posted by Dr. Thắng from UMC Ho Chi Minh City. So what he's mentioned is that in actuality in Vietnam, the hospital is already implementing the guidelines for no reuse of pen needle. In reality, a lot of patients, especially from the provinces, they still have the habit to reuse the needle, and this is something unavoidable to a certain extent. That's the first opinion. For the second opinion, for the new pen needle, the new generation, which is the Pro pen needle, there's a mentioning that it brings benefit to patient. Like for example, it's less painful, it's more easier to use, but he didn't see any. He does not see very clearly the connection between the benefit of the new pen needle to the glycemic variability benefit for the patient. So if possible, can you please share some experience for your patient who have used this pen needle before so that they can be clearer in terms of the benefit? Thank you.
Thank you. Thank you very much for your comment. All very, very fair and astute observations. I would just like to highlight that actually the kind of challenges that Vietnam faces with regards to pen needle reuse and also the cost of the needles, and therefore a lot of patients will want some cost saving, and therefore they might reuse the needles. The same thing applies to Singapore, because a lot of my patients, in fact, all of them have to also pay for their consumables. And so I tend to take a very practical approach with them. So what I do is I tend to look at the injection sites. And if the injection sites are full of lumps and there are a lot of needle marks, there's a lot of bruising, then really reusing of pen needles, I try to encourage them to keep it to a minimum. And I do that by trying to tell them, look, if you keep injecting into these sites, if you keep reusing your needles, it's not going to get any better because the absorption is going to be less. And so, and at a minimum, I kind of try to encourage these people to at least change their needles once a day. So if they're on 3 quick-acting insulins and 2 background insulins in a day, that means that, every 3 times they change 1 needle for the quick-acting insulin, and for the background insulin, for every 2 times they change it once. So hopefully we can have a consensus between the patient and myself as to what they're willing to do. Then the second point was that, in terms of the glycemic variability, how that it doesn't seem to be that much difference. I think, there are a lot of factors that you can see from the presentation. It's not just one factor alone. It's really the consistency in achieving, first of all the various structure that you're asking the patient to do. So glycemic variability is one of those things whereby you're trying to give the patient pointers as to how to minimize it. There's no way that you're going to be able to minimize it 100% of the time. But if they have a structure such that they do the before meal testing, the before meal cup counting, and then trying to get the injections at sites that are not lumpy, that then enables the absorption in a consistent and even manner, then using needles that's not going to deliver sometimes to muscle and sometimes to subcutaneous tissue, and then getting them to inject for their insulin 15 minutes before they start eating, you're getting a much better chance of getting them, first of all, lower glycemic variability and closer to target than you were ever before. And very often it needs repeated rounds of trying to tell your patients to do that. So usually I see only fruition, so maybe 3 months down the line. And then just another thing to note is that I know that CGM may not be commonplace in Vietnam at the moment, and it's expensive. So even in Singapore, not all my patients use it all the time. Some of them might use it once a month, which spans for 2 weeks. What I try to encourage them to do is to do frequent capillary glucose monitoring, at least 3 to 4 times a day. There's some really nice data that shows that if you can get your patients to monitor the glucose 3 to 4 times a day, and if they can achieve 70% of the time more than 60% of the time between 3.9 to 10 based on capillary glucose readings, that you're going to be able to help them achieve a lab measured A1C of less than 7.5%. So even if you don't have CGM available, you can still use the readings to try and get them towards the glycemic target they need to be.
Thank you. Oanh có ý kiến gì không?
Cô em có ý kiến là hồi nãy có cái báo cáo á, cô bên Singapore nói á, là khi mà chích ở cái bụng á thì cái áp lực nó sẽ cao hơn chích đùi. Cái đó cũng đúng nguyên lý vật lý thôi. Từ vì khi mà chích bụng á, dù em chích vuông góc với bụng nhưng mà nó là mặt thẳng ngang, nó không có áp lực trọng lực. Còn khi chích lên đùi á, là mình ngồi thẳng, cái áp lực trọng lực nó có phần thêm, cho nên chắc chắn là cái áp lực khi chích đùi nó sẽ thấp hơn là áp lực khi chích bụng. Từ vì nó còn thêm áp lực trọng lực nữa khi chích đùi. Chứ đâu nó có áp lực ở đùi nó sẽ thấp hơn, tự vì có trọng lực nó tiếp hỗ trợ nữa về nguyên tắc vật lý, cho nên khi chích đùi thì chắc chắn áp lực nó sẽ thấp hơn, cái áp lực mà mình đặt lên cây kim nó sẽ thấp hơn là khi chích bụng. Đó là nguyên lý vật lý á. Cái thứ hai nữa là ở Việt Nam mình á thì thông thường á, là bảo hiểm y tế sẽ không chi trả cho kim, do đó một số bệnh nhân người ta cứ hỏi mình á là người ta chích thêm được một lần thứ hai hoặc lần thứ ba hay không. Thì thật sự ra bệnh nhân không có tiền á, thì mình cũng tập cho bệnh nhân, thì mình sẽ chỉ bệnh nhân cách tiêm đúng, là tiêm đúng cái mặt phẳng, đồng thời khi mà rút kim ra thì không có sát trùng đầu kim. Thì em muốn hỏi cổ là cái nghiên cứu á, mà chích lần 2 á, mà cái kim nó đã cong á, là cho tất cả mọi cái chích lần 2, hay nếu đúng tiêm đúng kỹ thuật thì nó có bị cong kim như vậy hay không? Mình có thử làm một cái nghiên cứu á, nếu mà chích lần 2 đúng kỹ thuật như BBD hoặc là bác sĩ ở bệnh viện hướng dẫn á, thì tất cả mọi cái kim nó đều cong như vậy, hay là nó vẫn giữ nguyên cái vị trí?
Chắc chắn là nó phải cong. Em gì không? The question is that in Vietnamese the cost of the needle is not covered by medical insurance, so the patient must pay from their own pocket. So most of the time, I think that many places like this, the patient would like to reuse the needle. So the question is that is there any study about the use of the reuse needle and the influence of this reuse to the deformity of the tip of the needle? Is there any...
Yes, so if you see those electron microscopy images that I put out, those are those were looking at the needle reuse and what that does to the needle. Now, it is a very, very practical question that you're asking, and it is something that's across in all Southeast Asian countries, because all the diabetes consumables like needles are all paid for out of pocket. So we all suffer the same difficulty. Now, so it's a call to companies like BD to take on board that feedback, but also on the other hand, for healthcare professionals, it's really trying to rationalize what you can help your patient with. And so, if their injection sites look pristine, and if they're using their needles less than 5 times a day, I might not say anything too much about it. Okay, but if their injection sites are horrible, like if they have a lot of lumps, and if you feel the abdomen, for example, and quite often you might not see the lumps straight off, but actually if you palpate deep down, they actually have hardened areas. Those are the ones that are in trouble. If ever, you see, it's because I also run an insulin pump clinic, and I've got over 90, coming close to 100 insulin pumpers now. And I noticed that the ones who had a lot of site issues, a lot of not rotating their sites in the past, a lot of hardened areas. When they go onto the pumps, that's when they get a lot of site kinking and cannula problems. So we don't see that visually, but actually we know that that's what happens now. So it's really trying to minimize the needle reuse such that they can have good, consistent insulin absorption as much as possible.
Yeah. And one other opinion is that the injection site, because if you inject in the abdomen, there's no interference with the gravity. So the force will be higher than if you inject at the thigh. Is it correct?
Yeah, that wasn't quite what was shown in the in one of the other studies I presented, in that the injection force that's needed for the thigh appears to be higher. Because I've seen a lot of children coming out from the ped sector going out into the adult sector, very often in kids, the pediatricians are telling them to inject in the upper arms and into the thighs. And so when they grow up as adults, actually you have less subcutaneous fat within your limbs, upper limbs and your lower limbs. And very often when they're injecting the thigh, they end up with a lot of bruises. I don't know if you've noticed that as well. They get a lot of bruises, and actually it's quite painful quite often. And so actually the injection force into the thigh, because you're doing it at 90 degrees into your thigh, you wouldn't expect the gravitational force to be any different from injecting the abdomen, because you're doing it at 90 degrees as well. But in reality, the study, as I showed you, the amount of force you need to get it into the thigh is higher than into the abdomen. And in general, I try to persuade them to use the abdomen than the thighs, because I see a lot of bruising in the thighs. Mm-hmm. And very often, even if you're using the short needle, the chances of hitting muscle is actually higher in the thigh.
And do you think that in the abdomen there is less nerve conduction than in the thigh and the arm?
In terms of pain, you mean? Okay. Yeah, in the abdomen, if they have sites that are very, very lumpy, the one thing I do to manage the patient's expectations is I tell them that if they're going to move the sites, typically what I see is that in the lower abdomen is full of lumps across the whole band. And so if I tell them to move it further up, a lot of them tell me, I don't like using that site because it's painful. So even with the shortest needle, it's painful is what they tell me. And I always remind them it's painful because that area is hardly used. It's not used as pristine. Whereas when you have scar tissue and you've done it repeatedly, it hurts less. The other thing, I also remind them, when you move it to the upper abdomen, you're going to find that you're going to need less insulin, particularly around meal times. So be careful about your bolus insulin doses. You might need less. And so then that manages the expectations. They know what to look out for. They know that maybe it might hurt a little bit, but you know that they're expecting that to come along. The other thing I always remind them is that if you don't want to move it, if you keep injecting into that lower abdomen, that lumpy site, it's only ever going to get bigger. So especially for young girls, they don't like that. They want to move away from that. So, and the last thing I say to some of them, particularly if they're on Lantus insulin, I'm sure you've had feedback. Lantus insulin, it stings. Have you had feedback from your patients? It stings because Lantus is prepared in a lower pH. Its pH is 4.5, so it's a little bit acidic. And when you inject it subcutaneously, it then precipitates, and that's what, that's how they create Lantus. And so, sometimes you just have to ask the patient, is it more painful with this particular insulin or the other one? And then it helps them realize as well, it's actually the insulin. It's not necessarily all the needles.
Yeah, thank you. Biết nào có ý kiến?
Hỏi một chút thôi. Cái kim BD 4mm mà Pro ạ, thì thấy ghi trong đấy là có thể thích ứng sử dụng cho tất cả các trường hợp. Tuy nhiên có một số các trường hợp bệnh nhân rất là gầy, nhìn thì da tới cơ luôn chứ không thấy cái mô dưới da, hoặc là những cái ca rất là mập, thì cô có lưu ý mình vì những cái vấn đề, những cái trường hợp như vậy không?
So Vietnam, the frame of our diabetic patient is very different. There are some people very thin, with no fat tissue as all under the skin, and some people may be very fat. It's a lot of subcutaneous fat. Is there any difference in the cases with the new needle of BD 4mm long?
Thank you very much. This is a very, very relevant question. So actually in Singapore as well, when we looked at our diabetes registry, and we have over 180,000 people in this diabetes registry, and then I looked at the BMI, and actually a quarter of this 180,000 with type 2 diabetes actually have a BMI of less than 23. So that's 25% have a BMI less than 23. So we do, as Asians, get sort of leaner onset type 2 diabetes. And if you think about it, the skin is about 2 to 2.5 millimeters thick, whether or not you're obese or whether or not you're lean. Particularly with the lean individuals, I always go short needles. Up to a year ago, some of my endocrine colleagues were still using 8 mm needles. And essentially, I got Novo Nordisk to take away the Novo Fine needles for 8 mm, and I said, that's just too long a needle. And so, in the international consensus guidelines on needle injections, that's the UK FIT guidance, even in Caucasian populations who are typically bigger and fatter, 4 mm needles, max 5 mm needles should suffice in everybody, should be enough for everybody.
Thank you.
Em muốn nói về cái thay đổi vị trí tiêm thì hôm nãy có hướng dẫn là mình nên hướng dẫn bệnh nhân trích một cái vùng, ví dụ như 1/4 ở trên bên phải vài ngày, xong sau đó mình rời qua cái 1/4 trên bên trái vài ngày, xong luân phiên từng cái góc tư như vậy thì cái đó em nghĩ là cũng rất là cần thiết là mình thống nhất, bởi vì bệnh nhân thường là người ta rất là khó mà hiểu khi mà mình gọi là nói bảo người ta mình luân phiên vị trí trích, người ta không hiểu là luân phiên là như thế nào. Cho nên em rất là thích cái sơ đồ này, bởi vì sơ đồ này từ khi mà mình sử dụng thì nó làm giảm cái sự hiểu nhầm của bệnh nhân. Nên nhưng mà bây giờ đa số là bệnh nhân vẫn trích quanh đốn, cứ bên này bên kia giống như cô vậy đó. Thì cũng muốn hỏi cô là ở bên Sinh thì cái cách mà hướng dẫn bệnh nhân luân phiên vị trí tiêm thì có thay đổi theo tùy từng cái educator hay không? Bởi vì nếu mà mỗi educator nói theo một kiểu thì là bệnh nhân sẽ rối loạn hết, thì không hiểu là đi theo cách nào. Thì không biết là bên Singapore thì có cái guideline hướng dẫn về cái tiêm trích insulin để thống nhất những vấn đề này hay không?
So the question is that one of the most difficult for the patient to practice is that how to rotate the injection site. Most of the time when we teach the patient, they will only change the rotation at the other side of the
abdomen.
umbilicus. Yeah. And you have shown, and we have the schema here, is that there is a four quadrant in the abdomen.
Yes.
Yeah. And
yes, I like that.
Yeah. So we like this too, because if the patient understand about this, they will rotate in the right way.
Yes.
So the question
I
is
think
that
that's really nice.
yeah, and the question is that in your country, in Singapore, you have an educator and nurse educator, and when they teach the patient how to inject the insulin, do they use this one, or each educator have their own way? Yeah,
we have that with us for our use as well, and that's also, I like the turtle one that BD has for kids. There's I don't know whether they have that there, but so our educators do use that. But on the other hand, Singaporeans, the one thing bad about Singaporeans is they're so impatient. They really are impatient. So sometimes we just have to describe to them what to do, and most of the time they get it. But use whichever is helpful for you. So that rotation site that you have, that I would think that's really, really helpful for people to understand easier how to rotate their sites. Because you're right, what they often do is one time here, one time here, one time here, one time here.
Yes. And so in Singapore, each educator have
Big
their own
tentacles.
way of teaching, or they use the same the same kind of deliverance to the patient.
They do. So they rotate it according to this as well. But sometimes we don't always use that if that's not available at hand. Sometimes we just describe to them with our fingers, one time here, and go around in a snail-like fashion and say, once you've done 3 days work around here, move it to the next quadrant, and then so on and so forth. The problem comes in if they already have very lumpy sites, then you just have to avoid those sites. And typically, I usually manage their expectations by telling them they need to avoid it at least about 6 months for it to go down.
Dạ. Không có ý kiến gì.
Hi, Dr. Gardner, thưa cô, thưa anh chị. Khen một chút là em thấy là cái kim hiện nay thì tốt hơn nhiều so với hồi xưa, làm cho việc tiêm insulin mình thấy là nó dễ dàng hơn hẳn, nó cũng tiện so với cái việc dùng cái bơm tiêm, cái đó quá rõ rồi. Nhưng mà bây giờ cải tiến càng ngày càng cải tiến càng tinh vi, thì bây giờ nó có một cái mà em cũng hơi băn khoăn. Bây giờ cái kim bây giờ gần như là đồng nhất là 4 mm, thì cũng giống như chị Đào như vậy. Người bệnh thì có người mập, người ốm. Liệu rằng 4 mm nó áp dụng cho hết tất cả mọi bệnh nhân nó có phù hợp hay không? Có nhiều bệnh nhân rất là ốm thì tất nhiên là sẽ đủ rồi. Nhưng mà có nhiều người mập á, thì cái lớp mỡ nó dày thiệt là dày, thì 4 mm nó liệu có cần thiết không, hay là nhiều khi nó còn có một cái hiện tượng ngược là như thế này. Nhiều người bệnh nói rằng là sau khi tiêm xong á, là có insulin trào ngược ra. Nó trào ngược ra. Nhiều khi cái liều lượng nó cũng khá là ít, như tiêm 4-5 đơn vị insulin thôi, nhưng mà họ thấy có một giọt thuốc nó trào ngược ra, thì mình cũng lo lắng, cũng băn khoăn là không biết nó có ảnh hưởng gì tới hay không. Nếu những trường hợp đó mà cái kim nó dài hơn thì hy vọng rằng là ít cái bị trào ngược ra hơn. Thì không, cũng nó có băn khoăn đó khi mà sử dụng cái kim nó quá ngắn. Và một số bệnh nhân cũng muốn là thôi cho tôi dùng cái kim cũ đi, kim cũ đi, 6 mm đi, cây này ngắn quá, họ cũng không an tâm. Thì đấy là cái cảm nhận của em trong thực hành.
Dr. Chung asked about the dribbling of the insulin after injection. The dribbling.
Yeah. Okay. I understand what you mean. Thank you. Very practical question. So some of my patients do tell me that, but if I use this needle, I see insulin coming out at the top of the tip, after I've injected. And very often, two things in my mind. One of it is that they've injected into a lumpy, hardened site. So that wasn't a very good site to begin with. Second thing is that you need to remind them not to lift up the skin fold until it's really, really tight and taut. And while they inject, because in doing that increases the pressure of everything. And so it's really to gentle skin fold and then inject 90 degrees, count for 10 seconds after the plunger is down, remove it out, then release the skin fold to minimize, and to allow all the insulin to go in completely. So it's really pristine sites rather than lumpy sites to try and avoid that. And then press down the plunger for count up to 10 seconds, and then pull it up, and then release the skin fold. So I think it's partly technique. Does it matter to the blood sugar levels? At that point of time, you might have missed out on some insulin. The sugar levels may run a little bit higher, but maybe they can correct at the next meal. So that's okay.
And is there any correlation with the length of the needle? Where if the patient is too fat? No?
I think that is largely anecdotal, but if I have very, very lean individuals, then I might find that even with the 4mm needle, that sometimes that happens. So I have a very, that picture I showed you with the lots of bruises on the skin, that individual is so lean. His BMI is only 17. And so sometimes it does happen. So if you get very lean individuals, sometimes that can happen. And so some of them, you might just get them to just pull out a little bit more of a skin fold as much as they can. But being very careful not to scrunch it up so tightly that you end up pulling muscle in.
Yeah. Nếu mà mình bỏ cái áp lực ngược lại rất nhiều. 3 cái kiến hiểu không?
Thì em có một cái ý kiến về cái lực tiêm insulin. Thì là cô nói nó phụ thuộc vô cái vị trí mình tiêm, cái liều insulin cũng như là cái thiết kế của cái kim. Thì thực tế đó nó có những yếu tố khác. Tôi muốn hỏi cô này coi có những cái nghiên cứu nào hay những cái tài liệu nào cho thấy là nó còn phụ thuộc vô cái người tiêm nữa. Tại vì một số bệnh nhân lớn tuổi đó có cái tình trạng nó gọi là sarcopenia, cái cơ nó mong manh lắm, nhão. Thứ hai nữa là cái lực tiêm nó phụ thuộc vô cái gọi là cái grip hand, tức là cái lực bóp của cái tay của mình nữa. thì nó cũng có ít nhiều có thể ảnh hưởng đến cái lực tim. Ngoài ra thì chưa thấy cô đề cập là cái thiết kế của cái bút nữa. Thì mỗi cái bút của mỗi hãng á, ví dụ như Black Pen thì nó khác, Blackstone thì nó khác. Thì trong thực tế á, khi mà em sử dụng Blackstone á, mình bấm một cái là nó xuống luôn. Còn cái Black Pen á, nhiều khi mình bấm từ từ vô nó mới vô. Thì không biết là cô có cái nghiên cứu là liên quan về cái thiết bị của cái bút tim, tức là ngoài cái thiết kế của cái đầu kim mình, là cô nói là có những tốt như vậy, hoặc là trên những cái người mà lớn tuổi mà có cái tình trạng sarcopenia và cái tay nó yếu á, thì liệu tiêm insulin á nó có khác biệt không?
The question is about the force of insulin injection, the strength, and in all very frail patient with sarcopenia, and the hand grip is very feeble. Is it that any influence to the force of injection insulin into the subcutaneous area? Do you read the last question? The last question is about the force, the strength of insulin injection. In frail elderly patient, they have a sarcopenia, and the strength of the clip hand is very feeble. So how about the insulin can come into the subcutaneous area in these cases?
Yeah, I apologize if I've missed some of the question because my internet went off and I just logged back on. But if I understand your question correctly, you're asking about in the elderly population with a lot of sarcopenia, and they might have very little subcutaneous fat, and also they're going to struggle with the force of injection as well, whether that's going to be a problem and a challenge and how to overcome that.
Yes.
Is that yeah? So in the elderly population, it gets a bit tricky. This is when, if they have lost quite a lot of body weight and they're quite frail, we do have to assess from case to case whether or not they're able to inject. But here's what I'll put to you is that having a pen device is far more convenient for people than having the insulin syringe. So imagine if you're elderly and you're trying to pull out the insulin from a cartridge or a vial, and then trying to connect on the 6 ml needle into the syringe, trying to look at the markings to see whether it's at the right marking and the dose is correct, and then trying to get it in, and then with the insulin and the syringe trying to push it in. That's way more complicated than using a pen device, putting on a needle, just dialing up the dose they need. Sometimes they can hear as well the clicks, so they know each click is 2 units, that sort of thing. So they can count out the clicks. And then you have to look at that, assess their eyesight, whether they're able to do it. And actually, if you can imagine, pressing down the plunger will be a lot less pressure than trying to push it in with a needle and syringe. And if you, I don't know whether you've come across the newer Novo Flex Pen, but now they have a newer pen device, which is even easier to press down. And the same thing goes for the new U300 Tojo pen. So increasingly, the companies are realizing that they need pen devices that are much easier for people. And so the plunger actually doesn't require that much force anymore. So using short needles together with the better pen devices is probably going to help you overcome most of those difficulties. But definitely for the elderly population, a pen device would be way better than using insulin and syringing it out from there.
And another question.
If they can.
Yeah. And another question that Dr. Khoa would like to ask your experience about different kind of pen, because in Vietnam we have many kind of pen, and is it interfere something with the force of injection? Is there any correlation between different
newer pen devices? I forget the name suddenly, but the ones that they use in Saxenda and the ones that they will have in Rhizodeck, which is the co-formulation insulin. They are the newer and better pen devices. U300 Lantus and versus U100 Lantus pen device is also better. There's less force that's needed to push the plunger down. So I don't know whether you have that available in Vietnam already, the U300 large Lantus insulin.
Yes, yeah, we
Told
already
you.
have it. Yes, we have.
Yeah. So if you feel the pen device, it's actually a lot easier to press down. The other thing to remind your patients is that to always prime the insulin needle. I realize that a lot of my patients often forget about priming, and then as they have used insulin for so long, very often the first set of education they receive, they will already have forgotten. So from time to time, I do remind them, remember to prime your needles. With each new needle, they need to prime 2 units for most pen devices, but for insulin Toujeo, they need 3 units. So you need to remind your patients about that as well. But the newer pen devices that are coming out, they're a lot easier to push down.
Yeah, thank you. Mình còn câu gì nữa không? Chắc hết rồi. Hết giờ luôn.
Tức là chỉ có mỗi cái bút chỉ có prime lần đầu tiên,
Ừ.
hai đơn vị thôi. Tức là một lần đầu tiên.
Chứ không là hết đâu, không cần.
Một lần đầu tiên.
Yeah. Lần đầu. Cái pen đó, mình thừa cái pen đó. So I think that there's no more opinion, and I think that is lunchtime.
Okay.
But
All right.
yeah, thank you very much for sharing your expertise to us about the insulin injection. There's many things to say. The needle, the pen, the carb counting, how to follow your glycemic variability. And today I have learned a lot from you, and I hope that someday we can meet again and talk about something practical in real patient. Yeah.
Thank you very much for the invitation. Thank you very much for having me. It's been lovely to have a chat with all of you, and thank you once again for the invite, and have a happy end of 2020 and looking forward to a safe and happier 2021.
Yeah, yes, the same for you. Be safe and Happy New Year. I think
Thank
it's
you.
the coming New Year. And thank you,
Thank you.
MBD and all the participants. Bye-bye.
Thank you. Bye-bye.
Bye-bye.